So, hello everyone. Welcome to another subspecialty VMR about pulmonary critical care. Today we have three guests, namely Dr. Caitlin Batzlaff, Dr. Tyler Herzog, and Dr. Ashley Egan. All of them are from Mayo Clinic Rochester. And before I let them introduce themselves, I would start with Dr. Ashley Egan. She's a pulmonary critical care attending from Mayo Clinic Rochester. So could you please introduce yourself and also tell us why you chose the subspecialty and what you like to do outside of medicine?
Perfect. Thanks for having us. Again, I'm Ashley Egan. I am doing pulmonary and critical care medicine at Mayo. This is my second year as an attending. I chose pulmonary and critical care, I think mostly because of critical care to start off with, which I think a lot of us can say, and then pulmonary kind of grows on you as you go through it. As far as what I like to do outside of medicine, there's not a whole lot of time currently, but I bake and decorate cakes. And so I do that maybe once a month or so.
Very nice, thank you. So then I would start with Dr. Caitlin Batzlaff.
Hi everyone, I'm Caitlin. I am a first year fellow here at Mayo in Rochester, Minnesota. For the reason to go into pulmonary and critical care, I agree with Dr. Egan that critical care kind of grabs you at first and then pulmonary slowly kind of sinks its claws into you. For me, the ICU is a really nice way to stay broad in your knowledge base, but then see small changes make a big difference. And it's a minute by minute, hour by hour specialty, which I really enjoy. Hobbies outside of work. I like to cook a lot. So primarily eat vegetarian at home and love to explore all of the different spices that Asia and the Middle East and Africa offer. Because Minnesotans aren't known for their spice tolerance, a lot of people will claim that ketchup is spicy. So I'm working on that and I'm really excited to be here and go through the case.
Thank you so much. Then I would start with Dr. Tyler Herzog. Could you please introduce yourself?
Hi, everyone. So I'm Tyler Herzog. I'm another one of the first year pulmonary and critical care fellows here. So I actually was in the minority and became interested in pulmonary and critical care through the pulmonary side. I had some personal interest in cystic fibrosis, but then when I was in critical care in residency, that's when that really grabbed me. And so the balance of both pulmonary and critical care, where you have the minute to minute, like Dr. Batzlaff was talking about in critical care, but then more of the long-term relationships in the outpatient pulmonary clinic is kind of what really brought me into the specialty. And then outside of medicine, I enjoy a lot of different things. Of course, spending time with family and my dog is always fun, but also enjoy traveling when able. It's been a little difficult the last 2 years, but I'm actually in San Francisco right now at one of the conferences. Been able to get out a little bit today and see some of the city. And then also like going up to northern part of Minnesota, which is where we live right now, and going on some of the lakes and doing some water sports.
Thank you so much, you three, for the great introduction. And also, before we start the session, I would like our great scriber, Danny, and then our teaching point maker, Madalena, to introduce themselves. So I would start with Danny.
Hi everyone, it's so great to be here. My name is Daniela, as you can all see. I'm currently a fifth year medical student from and in Brazil. And outside of medicine, I really enjoy cooking. My specialty are all types of snacks, and I also really like language learning, which is what I always say, but really you can hit me up if you know French because I need to practice. So yeah, and I'll pass it to Madalena.
Yes. Hi, everyone. My name is Madalena. I'm finishing up my third year in medical school in New York City. I'm just so excited to be here and do the teaching points. In terms of hobbies, you all have shared such fun hobbies that I need to try out. But a new hobby I've gotten into recently is actually rock climbing. I've done with a few friends and it is very challenging, but very fun. So that's a new hobby I've been doing.
Wow, Madalena, you have such great hobbies. I mean, also you're a former, what was it? Figure skater. So
That's
cool.
right, yeah.
So then I would like to start the session. And Danny, could you please share your screen so we can start with the case? Okay, so as a case presenter, we have Dr. Caitlin, and I would ask her to start with the first aliquot.
Yes, so just first and foremost, got to have our disclaimer statement. So we've adjusted some of the details of this case in order to protect the patient's privacy and their identity. But we'll begin with a 60-year-old gentleman that is presenting with dyspnea and cough. His medical history is significant for metastatic, poorly differentiated non-small cell lung cancer that was diagnosed in June of 2020. Additionally, he has psoriasis, gastroesophageal reflux, and depression. His prior surgical history is notable for an odontectomy and a left shoulder arthroscopic rotator cuff repair. Medications, he's got a pretty small medication list. He's only on acitretin or soriatane, and that's a topical for his psoriasis. To briefly touch on his family history, he has a mom who had lung cancer, and that was in the setting of pretty significant tobacco use. And then his father had heart disease and the things that accompany with that, hypertension, hyperlipidemia, and additionally was a smoker. From a social standpoint, the patient is a prior smoker, has a 40-pack year history. They also have a history of alcohol and drug abuse, but they've been sober for many years. So to circle back to the cancer diagnosis, he was initially found to have metastases to his hilar lymph nodes, that's in the chest, and the right acetabulum. I'm going to pull up his initial CT scan and kick it off to Ashley and Tyler to discuss a little bit more regarding interpretation. And bear with me as I work on screen sharing. Give me. Okay, is everyone able to see my screen?
Yes.
All right.
Perfect. Thanks, Caitlin. So we'll go ahead and start. The image on the left, as well as the two in the middle, and perhaps Caitlin can help me with pointing, are CT images. The left being kind of taken in the apices of the lung and then moving more towards the middle on the other two images. The image on the left, as well as the one on the top, are lung windows, and you can tell that because it has a more white appearance. And again, we're looking at the patient laying on their back, and we cut them like a loaf of bread, so kind of this way. So you're looking at the patient from their feet, and so the left lung is actually on the right, and the right lung is on the left, and the lung should be dark gray with white specks, and those represent the vasculature. On that left image, you can see in the right lung that there's a bit of a consolidation there. And then if you went down in the CT, if you were to scroll, you can see that there's a mass along the right hilum, which Caitlin can point out for you. So this was his initial cancer. There are soft tissue windows, and you can see it's quite large there. And that was biopsy proven to be non-small cell lung cancer. The images on the right are PET images or PET CT, and we look for hypermetabolic activity to kind of guide us where our biopsies would be taken. So the top is again the lung, kind of the same cut, and you can see the red shows that it's very hypermetabolic. And so that's what we would go after with our biopsy. And then if you go down to the second image, that's in the pelvis, and you can see he's got some activity there in the right acetabulum, which would be consistent with the metastasis. And then the other red spot is his bladder, and that's just the radio tracer accumulation. And so that would be an expected finding. Anything I missed or anything you want to add, Tyler?
The only thing I'd add to is, looking at these images, the more that you look at, the more you're able to kind of interpret them and see what is abnormal. But if you're looking at those two middle CT images, you can tell that this mass is pretty large. And one of the ways you can see that is that black part in the middle is their airway. And usually that's nice and round. And in this case, it's actually almost pushing a little bit into the airway itself, just because of how large it is and how much it's pushing into the other structures in the mediastinum. So that's something that you can look out for as well. This person didn't have any airway compromise, luckily, but that's one thing to watch for as well.
So is this the end of the first aliquot, Dr. Caitlin?
So we're going through in a little bit of a initial history with some teaching points kind of sprinkled in, and then we'll circle back to his presentation that includes his exam and his vital signs. So for that poorly differentiated non-small cell lung cancer, he is currently being treated with carboplatin, paclitaxel, and pembrolizumab. And I know that these are names that kind of sound foreign to everyone, and that's part of the process of going through medical school. So I was going to kick it back to Dr. Egan just to touch base on one of those medications, specifically the pembrolizumab, to give a small teaching point.
Yeah, so carboplatin and paclitaxel are kind of your classic chemotherapy medications. But over the last decade and a little bit probably longer now, we've developed immunotherapy, pembrolizumab being one of those. Pembrolizumab, it's highly selective anti-PD-1 humanized monoclonal antibody, and it inhibits programmed cell death 1 activity or PD-1 activity by binding to the receptor on T cells to block the ligands from binding. And so when you block this pathway, it inhibits the negative immune regulation caused by PD-1 signaling. So pembrolizumab works by reversing T cell suppression and inducing an anti-tumor response.
So moving forward in kind of the patient's course, in July of 2020, they underwent radiation to that right-sided mediastinal mass that we had seen on imaging. And that was primarily because they developed symptoms, specifically hemoptysis. And then they additionally underwent radiation to that right acetabular metastasis, and that was secondary to pain. Moving forward in the fall, October of 2020, they did get a repeat chest x-ray and CT imaging that showed near resolution of this large right paratracheal mass and some new radiation fibrosis in the right medial lung. So I will share those chest x-ray imaging first. And we'll have Tyler comment on the chest x-ray.
Yeah, so as we move forward through this course, I want to just make sure that you guys see the imaging so you can appreciate how things will change over time. So anytime we're looking at chest imaging, first of all, it's important to make sure that you know, is this the right patient? Is this the right date? Of course, for this, we took off names and dates, but before you're even looking at the image, make sure that you know it's the right person, it's the right date. Here we're seeing essentially both a PA and a lateral film. On the left-hand side, the PA, and then on the right-hand side, the lateral film. And going through it, I'll go through the ABCD version. So for me, A is airway. So looking at his airway, it goes down and then actually deviates off to the right-hand side. But I don't see any kind of impingement from the outside. I don't see any obvious obstruction of the airway itself. For B, looking at bones, with this one, you actually have pretty severe scoliosis. You can see the spine bending from left over to the right and then back again towards midline here. For C, looking at the cardiac silhouette actually looks pretty good. You know, it's not any greater than 50% of the entire lung field, which would be an enlarged heart. And then we're not having any problems with seeing the actual cardiac silhouette itself, which could mean that there's a consolidation or something else in the lung. For D, looking at diaphragm, looks pretty normal on both sides. The right side is maybe up a little bit. That's the one Caitlin was just showing there. Maybe some slight tenting, but probably within the regular kind of limits of normal. And then you can either do E as effusions or everything else. I'll say E as effusions. So looking down at the very corner of the diaphragm, there's no blunting of that costophrenic angle, which would indicate an effusion. And then F, I say fields, and so that meaning lung fields. So now looking back at the lung fields themselves, first the left one looks pretty clear, but looking at the right lung fields up kind of near that right hilar area, there's a little bit of consolidation up there, more so than you would expect. And it looks like maybe a little bit of distortion of kind of the regular architecture. I don't think I missed anything else. Oh, on the lateral, I did want to mention, when looking through the bones, you can see down near the very bottom, near the inferior kind of vertebrae, there's some white opacity there, and that's actually probably vertebroplasty rather than something within the lung itself.
Dr. Egan, is there anything else that you would add?
No, that's perfect. Thank you.
All right, we'll move to the CT image.
So comparing this to the CT we saw before, again, we're kind of mid-level where his cancer was. And you can see there's a lot more consolidation now than there was before. And if you squint your eyes and look sideways, you could maybe draw a line straight back along that area of consolidation. And that would be consistent with radiation change. So all of that change was within the field of radiation for his lung cancer. Other than that, the right lung otherwise looks pretty good, as well as the left lung is completely clear. And then bringing up Tyler's point before, his airway is now opened up and doesn't appear to be squished anymore like it did before. And yeah, we would call this kind of fibrosis or scarring in that area, and that would be expected with radiation. And over time, it would kind of condense down and scar down more.
So after this imaging, he developed a significant cough. The cough started for a few weeks and was intermittently productive of sputum. The patient was given a course of prednisone and reported 70% improvement in their symptoms. As that course of prednisone was finishing around November of 2020, they had return of the symptoms to include cough and some shortness of breath. This prompted a provider to resume steroids and treat as if the patient had a diagnosis of radiation pneumonitis, so inflammation secondary to his radiation therapy. At this time, they did PFTs, or pulmonary function tests, and I will pull up the PFTs and share that as we go through. His PFTs demonstrated mild restriction and no bronchodilator response, as well as a mildly reduced DLCO. And so we'll let Tyler kind of walk through his PFTs, and then we'll go through an algorithmic approach to pulmonary function test interpretation.
All right, so I think we can stay on this one first if you want to, Caitlin. So first of all, this is of course a busy slide and something that I don't know if a lot of you have looked at pulmonary function testing, but most pulmonary function testing has actually even much more than this when you're looking at it. So the things that I bring my eye to first are that FEV1/FVC ratio. I'd start there because that will be your algorithm on how you kind of differentiate whether this is an obstructive process, a restrictive process, or something else. So you can see first that 79 is the normal, the LLN means lower limit of normal being 68, and found is what they actually got when they did the test itself. So that was 77.2. So his FEV1 to FVC ratio was normal. So next then, where am I going from there? I'm actually going to be looking up at the next two values, that FVC and that FEV1. And in this case, we had highlighted them orange because they are smaller or lower than our lower limit of normal. So with that, they're about 70% or so. So now, in order to determine whether this is essentially a restrictive process, we want to even look up a little further and take a look at that TLC. So let's see, with that TLC low, we see it up there, 70%. And with this one, that's where we're then being able to confirm our findings. If we go back to the next slide, Caitlin, if you want to go forward to that one. What I think is a nice thing here is we've laid out kind of one of the algorithms that we can use. There's been many different algorithms that have gone through over the years. One of the ones that's most often used is from the American Thoracic Society and European Respiratory Society guidelines from about 2005. And this is essentially a takeoff of that one. So you start at the top with this algorithm, you look at that FEV1 to FVC ratio, and then you say, is it low, is it normal? And it brings you down one of these pathways. So if we're going to go down, let's say we'll go down the right side. So say that it's low. Then we're going to take a look at that forced vital capacity or vital capacity, depending upon what they got done. And if it's low, then you're going to be taking a look again, like we did before at the TLC. Let's say the TLC instead was high. So you have a low ratio, a low vital capacity, and the high TLC. Putting all those things together, you actually have an obstruction with hyperinflation. So that'd be someone like a end-stage COPD who has a lot of air trapping, and because of that air trapping is now have hyperinflation. And in order to determine the grade of it, you take a look and you look at the FEV1 and say this is moderate obstruction, severe obstruction, etc. with hyperinflation. And then you look at your other values as well, that DLCO, in order to say if there's any other process going on. Or we'll do one on the left-hand side as well. So if you go back to the beginning, that FEV1, FEC, let's say that's normal instead. Then you take a look at that vital capacity or that forced vital capacity again. And in this case, let's say that's low. You go down to your TLC, and if your TLC is low, then you know you're on a restrictive process. And so you can grade it based on the restriction level itself with the TLC. And again, you need to finish up and make sure you're not missing anything else. And so you take a look at that DLCO value, and you can see, is there some sort of parenchymal problem as well? Or is this more of a chest wall limitation? And that can help you sort that out. Anything else, Dr. Egan, you wanted to mention on this one?
No, perfect, thank you. Kind of briefly talking, I saw there was a question in the chat box about radiation lung injury. So this is often difficult to diagnose because there's generally other conditions that are happening at the same time. So they might be distant because of their malignancy or because they have cardiac dysfunction. And radiation can affect any of the thoracic organs and structures. But the lung is one of the most sensitive tissues, limiting the success of radiation. And so when we think about kind of radiation lung injury, you have to be cognizant that there are other structures within the radiation field that may have been affected and causing treatment or causing symptoms. Radiation lung injury is estimated to occur in about 5 to 15% of all patients who receive radiation to the lung. And we make the diagnosis based on symptoms, timing, that they have compatible imaging, and that we exclude other causes. The way radiation works is by producing highly reactive free radicals that cause DNA breaks, leading to cell death. And then inflammatory cells infiltrate the area and clear the dead cells. And this can lead to a significant inflammatory reaction that becomes dysregulated and thus results in radiation pneumonitis, which we would consider early toxicity, or radiation fibrosis, which would be a later kind of irreversible toxicity. Several things can make a patient high risk of radiation pneumonitis. Those patients that are of older age, so greater than 65, female patients, and we tend to think that maybe it's because they have smaller lung volumes to start with. Patients that are non-smoking are actually more at risk of radiation lung injury, and we think that maybe it's because they already have destroyed lung tissue and so less tissue to damage, or because they have a decreased immune response from toxicity of smoking. Or is it because they have carbon monoxide induced hypoxia from the tobacco, and that results in less free radical generation? There's also things about radiation that predispose patients to getting radiation lung injury. So if you irradiate a large field, they're more likely to get pneumonitis. If you get a bigger dose, they tend to get pneumonitis. If you give them twice daily dosing of radiation as opposed to once daily dosing, they're less likely to get pneumonitis, although that's not really feasible in today's environment, right? Having somebody come in twice a day for multiple days in a row. Radiation pneumonitis can occur within 3 to 12 weeks of receiving radiation, and fibrosis may occur as early as 6 months, but can progress over years. Again, Caitlin kind of showed that last CT scan that showed that there was some ground glass opacities and consolidation within that straight line of the radiation field. And so that's why this patient was diagnosed with radiation pneumonitis. There haven't been many prospective trials about how to treat radiation pneumonitis, but most of us will give prednisone, about 40 to 60 milligrams a day, and taper over 3 to 12 weeks. And then of course they need pneumocystis prophylaxis because we don't want them to get pneumocystis pneumonia, which is a pulmonologist's worst nightmare. Patients with fibrosis are unlikely to benefit from glucocorticoids. When we give them prednisone, we would expect to see improvement kind of almost immediately, but up to 18 months after radiation.
Dr. Egan, thank you so much for this approach. Another question would be, is there anything to reduce the risk of radiation injury? And the second question would be in the chat, with respect to the patient, why did he undergo the radiation therapy?
Yeah, so 2 separate questions, great questions. The first one is if there's anything to reduce the risk, and not really. We try to limit the dose to the lowest possible effective dose that we can, and limit the radiation field, so not irradiating more than what we need to. Why did he undergo radiation therapy? So given the location of his tumor, it was very central. He wasn't a candidate for surgical resection. And so he underwent radiation and chemoimmunotherapy as definitive treatment. He also had hemoptysis. And so there was concern that perhaps it was starting to invade into a blood vessel. And so radiation can help shrink quickly to help prevent any complications from that. And then after all of that, I think Caitlin's finally ready to present the case.
An excellent review, and agreed. So now we've kind of come to this point where the patient has received chemotherapy, radiation, is on a steroid taper for presumed radiation pneumonitis, and it's now January of 2021, and they present to your office with progressive shortness of breath and cough. Initial vital signs: blood pressure 124/65, heart rate 80, respiratory rate 18, and they're saturating 91% on room air. The patient is afebrile. Initial exam: it is a 60-year-old gentleman in no acute distress, pleasantly conversant, no significant findings on HEENT exam. He does not have scleral icterus, and he has moist oral mucosa without any lesions. Cardiovascular, regular rate and rhythm, S1 and S2 are normal, good pulses bilaterally, and there's no lower extremity edema. On a pulmonary exam standpoint, non-labored breathing. However, you do hear scattered bilateral crackles. His skin is warm and dry without visible rashes, and the extremities are warm and well perfused. From a mental and neurologic status, the patient is alert, oriented, and appropriate, and their cranial nerves are grossly intact. Moving towards labs, he had a CBC that was notable for a white count of 6, hemoglobin of 10.2, platelets of 250, a chemistry panel with a sodium of 141, potassium of 4.2, chloride of 103, bicarbonate of 26, BUN of 22, creatinine was 1.1, glucose was normal at 150, calcium was 9. Liver function tests were obtained with an AST of 23, ALT of 14, ALK Phos of 85, T-Billy of 0.8, and an albumin of 4.2. Because this patient has had pretty extensive prior pulmonary history, CT chest imaging was obtained as the next step, and I will pull up that image now, and we can discuss the findings.
So looking at this CT scan, immediately you can tell it's a little bit different than the last CT scans that we were looking at. And so just to orient everyone, we're essentially looking at 3 different slices. From left to right is essentially higher in the chest down to being lower in the chest. And you can tell that because the airway in the first image is essentially one single airway. The second one, it looks like it's starting to go into the left main bronchi. And then the last one, we're actually below the level of the main bronchi and we're seeing the heart there. So with this, essentially we're looking at our lung views. That's that kind of more white view. And we can see that both parenchyma on the left and the right are quite extensively involved with this diffuse process. And we can see it almost throughout the entire lung, from the very high part of the lung all the way down into the inferior aspects of the lung. And looking as a pulmonologist, you can also see different lobes of the lung, the right upper, the right lower, left upper, left lower. They're essentially all involved by this process. Dr. Egan, anything you want to mention?
No, perfect. I would add that it has more of a ground glass look to it. So kind of that haziness, but you can still see the structures underneath, which is why we call it ground glass. Although there's areas of consolidation. So again, there's that area along the hilum that's related to the prior radiation injury. But then on the very far right image, there is an area of consolidation, likely not related if we were to scroll up and down. So I would call this kind of diffuse bilateral ground glass opacities with areas of consolidation and then evidence of radiation change. The question is what's going on with this patient and kind of where we come up with our differential. The patient, again, got radiation and he's on chemotherapy and immunotherapy. And so certainly we're always worried about infection, and he would be considered an immunocompromised host. We also worry that some of these changes may be related to the medications he's receiving. And so either the chemotherapy or the immunotherapy would be implicated. And then I'm always kind of the other else. What else could it be? Could it be something like organizing pneumonia or some sort of undiagnosed lung disease that he doesn't have, but that would seem less likely. Have you, this kind of off the cuff here, but have you guys ever heard of pneumotox.com? So maybe Dr. Herzog can help me out and type it in the chat. But Pneumotox is a website that has been put together that goes through all pulmonary toxicity of different drugs. So you can put in a drug and it will tell you kind of reports of what's been seen from a toxicity standpoint in the lungs related to that. And so I often use that a lot in clinic if I think that there's a drug reaction, to see, are these drugs the patient's been on implicated in the past or in other case reports.
Dr. Egan, thank you so much. I also have a question related to the diffuse bilateral ground glass opacities. When it comes to this imaging, is there anything like a broad differential that you have? Is it like more of an infection, or what can cause it, like the most common things?
Yeah, so we always think about infection because he's immunocompromised. It would be an atypical infection though, right? Because it's bilateral. When we think about kind of bacterial pneumonias, we tend to think that that's more lobar or occurring in one part of the lung as opposed to both lungs. Fungal infection can cause bilateral infiltrates, although I would say they tend to be more consolidative and not ground glass. Again, drug reaction can present with anything. It can be consolidation, it can be ground glass, it can be limited to one area, but it can be everywhere, kind of does whatever it wants to. And then you think of the other stuff. So things like when I think of diffuse ground glass, immediately I think of alveolar hemorrhage or bleeding into the spaces. But this patient doesn't have any risk factors for that. And so that would be lower on my differential. Tyler or Caitlin, anything that you guys thought of that I missed? Oh yeah, and of course, COVID. COVID can cause anything.
Yeah, no, I think that was a pretty broad, and when you're thinking about in general, not necessarily this patient, I try and put it into those big categories that Dr. Egan was talking about. Could it be infection? Could it be inflammation from something else? Could it be fluid? Some people coming in with bad heart failure and heart failure exacerbation, maybe not these images, but can have diffuse ground glass opacities as well. So those are just some of the things with more rare causes being like that hemorrhage or those kind of things. So I think keeping those broad strokes in mind and then starting to narrow down to, for instance, the COVID, the atypical pneumonias, the fungal infections within those categories is how I think about it.
I agree. I think having a large umbrella and then to be able to narrow down those diagnoses based on that. I like Rafa's blood pus water. That's good. So hit the nail on the head in interpreting the images and talking about a broad differential. In the setting that the patient is immune compromised, they were started on antibiotics as well as steroids, again, with a plan to taper those steroids over time. By February of 2021, the patient's symptoms unfortunately begin to worsen again as the steroids are tapered. And so I'm wondering kind of, Dr. Herzog, what would your next steps be to potentially investigate any infectious cause that might be more of a pulmonary specific test? And could you go through what that may mean for the patient?
Yeah, I'd be happy to. So this unfortunate gentleman has gone through a lot. He's gone through multiple different courses of prednisone and now antibiotics, and we need to get more information to find out what is going on in these lungs. So at this point in time, I do a BAL, and so that's actually shorthand for bronchoalveolar lavage. And it's a specific test that we do quite a bit in pulmonary medicine. So there's a few different types that we can do. Essentially, some of the ones that we have at our facility and most facilities will have these same kind of nomenclature, is either an immunocompromised host protocol or ICH protocol or a non-ICH protocol. So for people who don't have any kind of immunocompromised status, this will typically include a cell count and differential. It'll look at a gram stain and then a subsequent bacterial culture, a fungal stain and subsequent fungal culture, and then an acid-fast smear with a mycobacterial culture. But when you have an immunocompromised host, you want to make sure that you're not missing other types of infections that could be specific to this population. So we'll also add on additional tests, including Legionella, Nocardia. We'll look for Aspergillus. We'll look for pneumocystis, which we discussed a little bit earlier with the high doses of prednisone. And then we'll look oftentimes for some of those more specific viruses as well. So influenza, adeno, COVID that I know people were talking about before, RSV. And if you have high suspicion for any other specific kind of test, you can add them on as well. And that would be looking for instance like HSV or VZV, you could do that. If you have a very high suspicion for tuberculosis, we now have the ability to look for tuberculosis PCR as well, rather than waiting for the mycobacterial culture. And for certain areas of at least the United States, there's often endemic fungi. So you can take a look for histoplasma PCR or blastomyces PCR. And same all around the world, there's various endemic fungi from different places. So you could look for those specifically as well.
An excellent summary. Additionally, something that you could consider adding on in discussion with the proceduralist would be taking biopsies of a specific area of the lung. And so in this patient, they underwent both the bronchoalveolar lavage, so taking that washing of an area of the lung to look for additional infectious causes, as well as having a transbronchial biopsy, so where we take a small biopsy forceps and take small pieces of the lung and look at it either in real time under the microscope or sending it just to pathology. In this case, the patient was found to have acute fibrinous and organizing pneumonia with what they describe as rare, poorly formed, non-necrotizing granulomas. And so what does this mean? Unfortunately, it doesn't really give us a ton more information in terms of his exact diagnosis. And from my perspective in medical school and training, as soon as I heard granulomas, I tunnel visioned into, is this necrotizing, is it non-necrotizing? Because you're taught in medical school that pathology and test taking, the patients present like the textbook, but it's not very common in real life practice for patients to present as textbooks. And so if you hear granulomas, I want you to, instead of thinking about necrotizing versus non-necrotizing, is to first say, does this patient have an infection? And then say again, does this patient have an infection? Because that's really at the top of the list, as we've discussed. You can have both bacterial infections, you could have fungal infections. We already hit on the endemic fungi. And then some parasitic infections can present with granulomas as well, leishmaniasis, toxoplasma. And then thinking towards those non-infectious causes afterwards. So is this an exposure or a toxin that's potentially a drug that we're giving the patient? Is it related to foreign body from potential IV drug use? Or is there an exposure that's occupational causing a pneumoconiosis? Other things to think about that are a little bit less common are immunodeficiencies. So common variable immunodeficiency. Can consider inflammatory causes, so your ABPA, your pulmonary Langerhans cell histiocytosis, lymphoid interstitial pneumonia. And then malignancy is always a culprit. And then finally, thinking about your vasculitides, so your eosinophilic granulomatosis with polyangiitis, or your granulomatosis with polyangiitis. So it's really a big grab bag that can present with granulomas. And so it's something to be mindful of, always rule out infection. And interestingly, this patient did have some culture growth. They grew a bacteria called strep mitis, and they were given antibiotics. And I'm going to ask Dr. Herzog to give us just a brief summary about what strep mitis is, and if he really thinks that that's kind of our slam dunk answer here.
Yeah, so strep mitis, you may have heard of it before. Typically, it resides in the oral cavity, so anywhere from mouth, nasopharynx, throat. There are some isolated cases as well in other mucosal sites, so the female genital tract or the GI tract specifically, and maybe even the skin. And so it's possible, this can be something that happens in the lung, particularly maybe in someone with like a lung abscess who's immunocompromised. But in this case, I think it's less likely that it was the cause of everything that we are seeing on the CT scan. I think there's probably something else.
And so next steps, patient is given that treatment of antibiotics for coverage of the strep mitis infection, possibly, and then restarted on corticosteroids. And this is for a presumed different diagnosis, which we'll let Dr. Egan kind of go into a little bit more detail, but consideration for what we call immunotherapy pneumonitis. So one of our medications that we're giving the patient is causing this inflammation, and specifically it's the patient's pembrolizumab. Dr. Egan, do you want to give us a little bit more detail?
Yes, thanks. So immunotherapy, like we talked about before, encompasses the checkpoint inhibitors that harness the immune system to treat the cancer. And so there's the PD-1 and then the PD-L1, and then some of them are also the cytotoxic T lymphocyte associated antigens, so CTLA4. Immunotherapy has drastically improved the prognosis of patients with cancer, but they've come with this unique side effect, different side effects called immune-related adverse events that we're still learning about because these medications are still relatively new. The side effects are believed to occur because of immune enhancement and can involve virtually any organ. Common organs include the GI tract, the liver, the endocrine system, skin, heart, lungs. Pretty much if you have it, it can be affected. As far as pneumonitis is concerned, it's estimated to occur in 5 to 10% of patients receiving immunotherapy. and it's more common in patients receiving CTLA-4 inhibitors than PD-1 or PD-L1 agents. It can potentially be severe and life-threatening, and it can present as early as the first administration of immunotherapy, although the median time is about 2.8 months. Interestingly, patients can stop immunotherapy and still get immunotherapy-associated pneumonitis up to a year after discontinuation. And so that's an even harder diagnosis to make sometimes when they're not getting the treatment.
Something to always be mindful of in the world of advanced medicine and medical technology is that our treatments can have side effects and can cause harm. And so moving forward, it's now September of 2021, and the patient undergoes repeat CT chest imaging in the setting of tapering his prednisone and having worsening symptoms. Unfortunately, that CT scan shows worsening of his opacities throughout his entire lung fields. And so he is resumed on prednisone and then started on an additional medication called mycophenolate.
So just a quick word on mycophenolate. We think now we know what's happening with the patient. And so the treatment is really going to be tamping down the immune system effects. However, we don't want to stay on prednisone forever. We all know that it has quite a bit of side effects. So one of the things that we can use to try and spare some of the steroid is mycophenolate. So it actually causes a cytostatic effect on TMB lymphocytes. So it inhibits their growth, although it doesn't directly kill TMB lymphocytes. And the way it works is it's actually an inhibitor of, go with me here, inosine monophosphate dehydrogenase. Okay, I trust you don't have to remember that exact, but you can remember that inhibits de novo guanosine nucleotide synthesis. And so really TMB lymphocytes are dependent on that pathway in order to proliferate. So inhibiting that pathway means that you're going to be tamping down the immune system and the immune system's response.
I would just interrupt for a little bit. There was a question about the biopsy results where we are concomitant with granulomas. Thank you, Rafa. Yes, about whether the biopsy results with the granulomas are consistent with checkpoint inhibitor pneumonitis. And I would ask for Dr. Egan to say some words on that.
Yeah, unfortunately, pathologically, they can present with a variety of different things. And so you can see just diffuse damage. You can see the organizing pneumonia with granulomas. Interestingly, we're starting to see kind of sarcoid-like reactions where they really have granulomas throughout the lungs and in the lymph nodes. And so we're still learning a lot. By biopsy, it's not super helpful to rule in or rule out immunotherapy pneumonitis. What it's really helpful to do is to rule out other causes of lung injury so that this can be a diagnosis of exclusion.
Thank you.
And so now it's about November timeframe for this patient, and they're on both the prednisone and the mycophenolate and feeling much better. And so it becomes the time to discuss removing the prednisone because this is not a long-term medication. It has lots of side effects. And as they're tapering off prednisone, the patient is able to tolerate that without symptom recurrence. And so by December, he's able to come off mycophenolate as well. We were able to obtain follow-up imaging in March of 2022, which I'll pull up. And then if Dr. Egan, you'd like to comment on the images.
Yeah, so again, from left to right, starting at the apex and then going down, you can see that the ground glass opacities have essentially resolved. There's still that area of consolidation and fibrosis along the hilum, but even that has condensed down, which is what we would have expected with radiation. And so overall, his CT scan looks pretty remarkably normal, minus that area that Caitlin's pointing out.
Thank you so much. And he additionally underwent repeat pulmonary function tests, and that showed persistence of that mild restriction as well as the reduction in his diffusion capacity. However, he did not have further progression. He was able to exercise without the requirement of oxygen, and compared to prior, his expiratory flows, total lung capacity had actually increased. And then over time, we did see an improvement in his DLCO. And so overall, I would say positive outcome in a pretty sick patient that has had a couple of setbacks. Went over a lot of different things, both radiation pneumonitis and then some immunotherapy associated pneumonitis. I was going to let Dr. Egan just kind of end with a little bit more on immunotherapy pneumonitis, and then we can take other questions if you have them.
Perfect. So when we think about immunotherapy pneumonitis, we grade it by severity. There's 5 grades. Grade 1 is asymptomatic. And we find it only by imaging alone, usually with their surveillance imaging. Grade 2 is they're symptomatic and they have limitations on their ADLs, or activities of daily living. This is where this patient would have fallen into initially. Grade 3 is they have severe symptoms limiting even self-care, and they've become oxygen dependent. And then grade 4 is they have life-threatening respiratory compromise requiring intubation. And then grade 5, I don't know why we have a grade 5, but it's death. And so grades 1 through 5. When you get concurrent immunotherapy and radiation, you're more likely to have pneumonitis. And then interestingly, say you had radiation 5 years ago, and then you get immunotherapy, you can get what we call recall radiation pneumonitis in the area of previously irradiated lung. And so this can occur years after completing radiation therapy. Again, immunotherapy-associated pneumonitis is a diagnosis of exclusion, and you have to rule out other things, mostly infection. Patients with grade 1 pneumonitis, or ones that just have radiographic findings, are generally managed by either observation, close observation, or we hold their immunotherapy. Grade 2 and higher, we have to not only hold their immunotherapy, but also initiate immunosuppression. This is generally done with prednisone. And as you can imagine, giving them prednisone to suppress the immune system is kind of counteracting how the immunotherapy is working. So not only do they get a delay in treatment, but now we're reversing what their treatment was doing. And so it's not uncommon that patients have progression of their cancer while we're treating them for this side effect. When patients can't come off prednisone, we often will think about switching them to mycophenolate, just because we don't like long-term prednisone. But there are other treatments other trials looking at other treatments. So some places have started treating with infliximab. Some places are trying IVIG. There's still a lot to learn, and there aren't many prospective trials looking at treatment for immunotherapy pneumonitis. And I was happy to answer questions. I'm sure Tyler and Caitlin are as well. I see there's one in the chat.
Exactly. There was this question about what do you consider in lung cancer when thinking about resection versus drugs?
Yeah, that's a perfect question. And so usually if it's a stage 1 cancer, meaning that it's stayed within the lung and it's not involving any of the lymph nodes. If it's peripheral, we often refer patients to surgery. If they aren't good surgical candidates, or they prefer not to undergo surgery, then they go to radiation for definitive treatment. If it's involving kind of what we call N1 nodes, so kind of the very first lymph nodes, they're still sometimes candidates for surgery. But if it's involving any of the N2 lymph nodes, or kind of the mediastinal central lymph nodes, then they wouldn't be a candidate for surgery, and they would need to go to medical oncology and/or radiation. If it's a very centralized lesion like this patient had, often we don't do surgery, because in this case, it would have required a pneumonectomy. They probably had that discussion with him about pneumonectomy versus chemotherapy or radiation, but I'm suspecting that with the acetabular metastasis, that he was probably led in the direction of chemotherapy and radiation, which would be appropriate.
Another question from my side with respect to pneumonectomy. I know there are several criteria necessary to perform a pneumonectomy. Which are these criteria? But was there some kind of volume, lung volume that is necessary?
Yep. So in general, to perform any lung surgery that we're going to resect anything, they have to have generally favorable PFTs. So if we're going to do a lobectomy or even a wedge, we like for them to have no more than mild restriction or obstruction or reduction in diffusion capacity. To do a pneumonectomy, we would prefer that they have normal PFTs going into surgery. There's another question about, can you try other immunotherapy? And the answer is yes. And so some patients that get pneumonitis from immunotherapy, you can actually re-challenge them with the same drug, and only about 20% of them will develop recurrent pneumonitis. The same is true for switching immunotherapy. And so often we go between different classes and we watch them carefully, but they don't recur with the pneumonitis.
Thank you so much. Then I would ask Dr. Caitlin to start over with the case.
Say that one more time. I'm sorry, I didn't catch it.
So then I would ask you to go further with the case.
Gotcha. Yes. Yeah. So actually, this is pretty much our good wrap up point. So he was able to come off of the prednisone, the mycophenolate, and had clinical improvement with his symptoms, as well as improvement on imaging and pulmonary function testing. And so he's doing well and is in discussion with his oncologic team, excuse me, regarding kind of next steps in management of his malignancy.
Thank you so much. As a final diagnosis, would you write immunotherapy and radiation-induced pneumonitis, or how would you sum it up?
That sounds perfect to me. So initially radiation pneumonitis, followed by an immunotherapy pneumonitis.
Thank you so much. Then, first of all, I would thank you all very much. If you three have to say anything else, Dr. Caitlin, Dr. Tyler, and Dr. Ashley, thank you so much for coming. It was such an educational case. And due to this restricted time, I would lead the way to Madalena for the amazing teaching points she has made.
Yes, what an amazing case presentation and discussion, truly a masterclass. So I will try to sum up some of the teaching points that you all highlighted. So first of all, we learned so many great points just about how to interpret chest imaging. And first, when we look at chest imaging, we want to confirm the name and the date. But we went through a really helpful approach to chest imaging. So you can use the A through F approach, A being airway, looking for any deviation. B is bone, looking for signs of scoliosis. C stands for the cardiac silhouette. So you're looking to see if it's taking up more than 50% of the lung field. D is diaphragm, looking to see if one side is elevated. E can be effusion or everything else. And then F is the field, so the lung fields, for example. And then we went into a really fantastic discussion about immunotherapy options. And we talked specifically about pembrolizumab, which is a highly selective anti-PD-1 monoclonal antibody, which ultimately reverses the T cell suppression. And we learned a lot about immunotherapy-related adverse effects, which can affect truly every organ that we talked as we discussed. But specifically, immunotherapy-induced pneumonitis can present years after treatment and generally occurs with the CTLA-4 inhibitors more so than the PD-1 inhibitors. And lastly, we got a really fantastic schema on pulmonary function tests, which I will have to review many more times. But the kind of short summary is that the first step is we want to look at the FEV1 to FBC ratio, which ultimately informs us about whether it's an obstructive or restrictive process. And And after that ratio, we can look at the FBC and other values to narrow in on the differential. So I will pause there for time, but just what an incredible session and discussion. And thank you, Shema, for facilitating.
Thank you so much, Madalena, for your amazing teaching points. And again, thank you, Dr. Caitlin, Dr. Ashley, and Dr. Tyler for spending your time with us to give us an approach to pulmonary critical care medicine. I will definitely think of going into that field now. Thank you so
Excellent.
much, and also the whole audience for coming.
Thank you, guys.
We welcome you with open arms and happy lungs.
Thank you guys so much. Join us.
Bye.